Okay, thank you for joining Lab of Interview. This session is about the chip procedure complex, high-risk PCI and anatomic region. I'm D.W. Park from Assam Medical Center. I'm going to introduce and co-moderator Dr. David Smith, and we invited the world-renowned interview and Professor Ziad Ali and Professor George Dangas and Professor Sunao Nakamura. So I'm going to start this interview session with the first question to Dr. Smith, and your lecture is about the definition of a chip procedure, who are doing the chip procedure. And my question is about what are common definition of the chip procedure. Also, how about chip interventionist certificate, and every interventionist can do chip procedure, or how do you think about that?
Yes, it's a good question. It's a tricky one because I think not much in cardiology is actually made better by putting the word complex in front of it. And the reason I say that is there can be a tendency to overcomplicate anatomy and procedures as some kind of badge of honor. So use of impeller, use of transcaval approaches, use of LVAD, et cetera, the more complex you make it doesn't necessarily mean that you're doing a better job. So I'm slightly wary of the notion of giving people a badge and saying, this person is a chip operator, therefore this person is a better operator than you or me. Or you see what I mean? So I'm slightly wary of it. Of course, what is complex to one person is not necessarily complex to another, and what is high risk for one person is also not necessarily the same. There are some common features, and I discussed some of them in my talk. Poor left ventricular function, left main stem stenosis, calcification, tortuosity, last remaining vessel, big side branches you can't afford to lose, et cetera, et cetera. So these things will generally define complexity, but it really is very much an individually based decision that is very dependent on the operator, the environment, the procedure, the team, the hospital. So I've rather ducked the question, I think, in the end.
Great. So, and my question is, Professor George Dangas, your lecture is about in daily PCI practice, how can you do calcium management in the real world, and we are doing a lot of case of the chip procedure. Could you comment on that? What is essential? How can you do calcified region treat well in daily PCI practice?
That's a very important question because calcium is one of the big challenges and is related to the calcium regret feeling. If you don't treat it adequately and then you have a suboptimal result, after the fact of implanting a stent, then that's not a good time to deal with the calcium. You may regret you didn't think about it earlier. So I would say the approach first comes with a recognition that you need really something more than just a simple balloon. This lesion has a tram track, both sides of the vessel has calcium. Then you have to employ the imaging in order to plan better this angioplasty regarding the stent, the calcium depth, length, and depth. And then you have to be facile in the atherectomy technique. And I know there are many, but at least you have to have one that you're good at. And one can say choice of this, choice of that. You really need to choose the one that your laboratory and yourself more facile in using in the daily basis or in the weekly basis, and use this one. And following that, according to the imaging lessons that you have, perhaps you use additional or exclusively lithotripsy balloon for further expansion, and then only proceed with the final steps of high pressure balloon and stent. Mm-hmm. So you really need to focus on early recognition, have a plan inclusive of imaging of how to treat it, and employ the best technique you know and your lab knows about the calcium atherectomy before your stent.
Great. Ziad, can I ask you about the shockwave? I mean, shockwave is kind of new, if you like, to lots of labs as it's developing. One of the things I was struck by your talk, it was a terrific talk, I thought. I learned quite a lot from it. Do you think that, bearing in mind people are spending quite a lot of money on this technology, are lots of people using it without actually knowing how to get the best out of it at the moment?
You know, I think that's a very, very important point. In some ways, the ease of the technology is its curse, because it's sort of sold as it's a balloon, you turn it on, you press the button.
Yes.
But as you saw earlier from my lecture, there's a lot of nuance to this and a lot of misconceptions about how it actually works. We're trying to educate people on now that it's in people's hands and it's easy. I think the major advantage of Shockwave is that it's very easy to set up. It doesn't require any additional training in order for you to activate and implement it, but we do need to work on its utility and how it's best optimally used.
And do you think, I mean, I was struck by the end of your talk, I just wondered, are we going to get to the point where actually, if fluoroscopically you see any sense of calcification there, that actually think, okay, first off, I'm going to take my shockwave balloon and prepare it like that? Because I was particularly struck by how you were saying, oh no, you get those microfractures in all sorts of different places, like creating crazy paving, and then you can dilate it even with the same balloon and see, okay, now we're making progress. So are we going to get to a place where the balloon is made longer and is applied to, 2/3 of the length of the vessel that you're treating?
So these are in the works. I mean, we understand that there needs to be longer balloons. There probably needs to be more emitters. There needs to be balloons that have higher energy. There needs to be something that can handle the crossing profile. And obviously, those are all things that are being iteratively worked upon in some way, shape, or form. But taking cost aside, David, right? Like, why would you not do this? It's a balloon. You see calcium on fluoroscopy. You inflate the balloon. You press the button. It takes a minute, and you've prepared the entire vessel.
Yeah.
One thing I'd like to focus on is, so far, all the studies that we've looked at in terms of either clinical endpoint or acute procedural success comparing rotablation or any advanced lesion preparation have failed compared to balloon. And I think the reason that happens, in fact, I know the reason that happens is, the maximum calcified segment is like 5 millimeters. So we go there, we rotablate the crap out of it, and then we go in with this big balloon, we just crack it, and it's beautiful, and then we put a 38 millimeter stent. And then the minimal stent area is 22 millimeters from where you spent an hour preparing the lesion, and that's the rate limiter.
Yeah.
And the reason the rota didn't work is it was too big. The rota just flew right past it.
Yeah.
The NC balloon worked because it was eccentric calcium, and that's where the IVL, I think, could have the benefit that the others don't.
Yeah.
That you can prepare the lesion in this unbiased manner anywhere you're going to put a stent.
Yeah.
And that's where I think it could be a winner in terms of clinical outcomes.
And anywhere, even perhaps you're going to put a drug-eluting balloon?
Yeah.
Yes.
Absolutely.
Okay. So now, can I ask you why, at the moment with calcific lesions, we've underused technologies that are available, imaging, physiology as well, but focusing on imaging, why do you think it is that imaging is underused, and how can we introduce it into everyday practice? Is it cost? Is it time? Is it familiarity?
Actually, so Japan, all the equipment is reimbursed. Very crazy country.
Right. Yeah.
At first.
Yeah.
So the usual practice, we use the IVAS imaging more than 19%. That for us, using imaging is a very natural thing.
Yeah.
And especially we know and we think the imaging device for the calcified region is very important because of course calcified region is actually the last and very strong our enemy. We know that. And at first from this meaning, we should evaluate very accurately. We should evaluate. So from this meaning, IVAS or OCT imaging, and then think, and then at I think we should select appropriate device, appropriate region. So this is very important. So we always using imaging.
And do you think that if it was reimbursed in other geographies, that the use would go up a lot, or is it a mentality thing? Is it a
actually, my activity is outside Japan. It's maybe I think I'm a city operator,
yes,
and mostly outside Japan.
yes,
And then maybe I think 50-60% of my activity is PC activity is outside Japan.
yes,
I'm still using imaging in the case of cultural region, because I want to select the operator device. If we can select the operator device, maybe I think lead to reducing a cost also.
yeah.
But you know, David, one of the things that I tried to point out in the lecture is we have these free tools, right? Like device detection and stent
Yes.
boost,
Yes,
and nobody uses them,
yes,
Oh.
yes,
right? So a lot of what you need to know about
Yeah.
calcium is staring us in the face,
yes,
and we're not even using that.
yes.
No question, intravascular imaging allows us to assess for fractures, make sure the lesion is actually prepared. But we do have a crossing issue at the beginning. And where you want to deliver your therapy,
Yeah.
whatever it may be, NC balloon, we have these X-ray tools that can
Yes.
basically show us broken bones. They can show us calcium.
Yes.
So we should be using
Yes. Yeah. No, that's a good point. People do underutilize them. I think you either we have in our lab, some people who use it kind of all the time, and some people who go, we have stent boost? I didn't know that.
That's right.
Yeah.
So one of the surprising things, and I.K. Zhang is comment on in Harvard, and they do, previously in U.S., I know in the European country, less than 10% used for intravascular ultrasound. But I.K. Zhang commented nowadays 60-70% used intravascular ultrasound. Recently, Renovate Complex PCI published in New England Journal of Medicine. Intravascular imaging guided PCI much effective than angiography guided PCI alone. So what about some big trend in the US or European country? How about the overall penetration, overall use of intravascular guided PCI status?
I think for us, in the UK, it's time pressures, cash pressures, and also understanding and knowledge of the technology and interpreting the images. But if you have 10 cases to do in a day and the lab staff are going to leave at 5, then you have a choice. You either do the 10 or you do 6 really well, and the other 4 don't get anything. So it's quite tough, actually. That certainly, I think, in the UK drives quite a lot of this. George, you
It's sort of the same mix, how they practically apply it. And you see labs that are made a decision to actually figure out a way, not just leave it up to individual person, individual operator, do whatever you want. That never really works. The culture of the lab is that we all going to decide that we want to have this. You organize, you have a special trained assistant techs who take care of the machines, bring the machines, set up, because there's a component of all these techniques that it's outside the reach of the scrubbed, sterile operator. And that makes a difference. In the old days, you had to scrub out, do whatever you have to do in the machine, the scrub that again. That's not really practical. And now as we get more technology enhancements, I would say, tools, some of them have a tablet which can be under the sterile drape, and you can just push some buttons and essentially make it a little bit more friendly without having to scrub out. Or if you want to, they have creating some scenarios of analysis that you can select. You're imaging and you're doing an ISR analysis, you're imaging and you're doing a calcium analysis, that they can have AI products that sort of help automate the analysis as opposed to, again, have to go back out and do. And the best way is that the lab employs some type of a team that comes in with machines, helps, and perhaps offline analysis of the studies also can help with the related research and all that.
It's called a fellow, isn't it?
It could be any. It could be a fellow. It could be a tech. It could be. But essentially, they have an interest, and they have a job and a duty, and a job description to maintain the machine, figure out the machine, bring the equipment, help with the analysis, know how to plug it in, plug it out, and all that.
Yeah.
And these are the labs, and then start having easier productivity on how to
Of
do
course,
that.
the more you use it, the quicker it becomes, the more it works, the
That's
better
right.
it works, the better everything works.
And very often you will see the regular staff, they're facile then because sometimes they don't call them anymore in some simple cases because they know or by the utilization, everybody learns.
And how does this work in your experience for something like Impeller? So it's something that's a rather bigger technology. What's your view of Impeller? Is it overused in PCI generally? I don't know if I'm allowed to ask that question, or what's your feeling?
I'm sure again it varies. There's some labs and some areas that use a lot and some others use other. And depends also in different countries, the reimbursement environment. The ECMO may be used more than Impeller, some other aspect of hemodynamic support. In general, the hemodynamic support is a patient component and a procedure, I would say, heart-related component. Does this heart need the support? And then there's a second component, which is the vascular. Can it fit? And how do we safely put it up? And a lot of the complications, really, and the safety concerns come from the second part. And that may create some phobia. That's another aspect of like, can an operator who is familiar with 5, 6, 7 French sheaths, all of a sudden, occasionally, put an 11 French sheath in and do that safely. And the question is maybe not so much. And again, there is kind of an adverse reaction. But now with more familiarity with the TAVI and other large bore access, I think that increases. But really, the technologies has to also be miniaturized. And I think specifically Impeller is underway with this program of miniaturizing. And I think that's actually what made the balloon pump very successful. Original balloon pumps were 10 French. And there was a difficulty in hemostasis. They really became very, I would say, facile for everyone when they come down to the 7 to 8 French sheath range.
Does anybody use a balloon pump anymore in America, for example?
Of course.
Yes? Okay. For supporting an intervention.
Yeah, why not? It's easy. Anybody can put it in.
Absolutely.
Why? Because it's safe and it can fit.
Yes.
Otherwise, you go into, you have to be ready to say, okay, can it fit? Can I do an angiogram? Can I do an ultrasound guide? Can I understand? Does it fit the device or not? That's where all the registry data indicate we have some safety concerns. They all come from the vasculature. They don't come from the heart. They come from the vasculature. So that's where you have to be careful.
My one concern is about, our intervention cardiologist next target is about the much complex, the MCS supported complex PCI. I saw some live case and put the Impeller and then try to open the 3CTO. And the much complex left main intervention is candidate bypass surgery. So that is my concern in that, our daily practice PCI much complex given Impeller supported, PCI.
I mean, that's happening. We know that if you have an Impeller supported PCI, you're more likely to get a complete revascularization. That doesn't mean that's necessarily good on a single setting.
No,
right? You can only beat up the heart so much before there's a cost to it.
Sure.
Right?
Yeah,
But that is part of the goal of it, is that it takes that pressure off you in terms of, I can only do one, or I'm running out of this, or I'm running out of sort of myocardial jeopardy or hibernation after PCI. You can do a complete revascularization with an Impeller.
You have more time to spend in the coronaries. Whatever it means, you do more vessels, or you do a better job or a more detailed job in a highly calcific bifurcation lesion without being concerned that the patient is crashing while you're doing all this complex atherectomy and lithotripsy and crossing and, kissing balloon and maybe crossing the stent and maybe have a secondary bifurcation further down distally. Then, you feel under pressure if at the same time the patient is hemodynamically unstable. Then you cut steps, perhaps get not a good result. So that definitely it's a good thing. Now, from that point on, going to do this in all vessels at the same time just because you can, I agree that may not be necessarily the best use. But clearly you can choose and do a great job in the main targets of the patient, and perhaps you can leave a smaller part for later on.
What does everyone think about the question you first asked me right at the start? This idea of accrediting people as complex operators. I'm kind of rather averse to it because it ends up with the idea that, oh, I'm a better operator than that person. Do you know what I mean?
Well, let me tell you. I think
there is a
we have.
very difficult question. Yeah. How do you think?
Well, I tell you that there is a certification, let's say, for interventional cardiology,
Sure.
and I would like that to cover everything.
Yes.
The more you ask, the certification, the more certification, the more you can achieve as many. Then this means you got to maintain all of those, and then that only happens that 10 years down the line, the same people are going to complain to the professional societies. Why are you making us pay all this, or not us, but driving all the certifications is a cost. And after wanting to achieve the glory of the certifications, then later on, each one comes with a renewal cost, which is quite burdensome if you keep adding. I think we have so many certifications already in cardiology. Nuclear, echo, CT, so many. Intervention.
Yeah.
Potentially talking about structural. Then within structural, heart failure, you're talking about types of structural, TAVI and mitral. Now you're talking about CHIP PCI, you're talking about 10 certifications within cardiology.
Yeah.
Am I asking for an EKG certification as well?
That's a great idea.
Well,
You're onto something.
What about a
Don't tell the ABIM.
history-taking certification?
well, I mean, at some point it sounds like a good idea.
No, I think it's a bad idea.
It's a good idea to direct, to find a way to rate expertise in general, and patients want that. And the different thing to say that I have a set ways and everybody has to abide and you have to do it and that certification. I'm averse to the idea of multiple certifications in general.
Because actually a lot of the things that people are learning about complex or higher risk PCI, a bit like in the CTO space, that afforded other people who don't do CTO skills to help learn how to do what PCI they do better. And it's the same perhaps with the high risk or CHIP PCI. Do you agree with that?
That's right. I think whatever you're asking about the CHIP PCI, we heard about the CTO PCI several years. Or the certification of the CTO PCI. It goes without saying that people have to do what they know what to do. That's what I said before. You don't listen to a lecture and we talk about all possible atherectomy, atherotomy, this, that, At the end of the day, your lab, you had to have one, and you really know that one very well. And then you go with that one. Why? Because that's why you have. Forget about what the talk and so many possibilities. Ultimately, what is your what is your choice? And your choice cannot change. Are you going to use this one in one patient, this one to another, and then you're going to know nothing really well. In the end of the day, you have to also be a mature person and not attempt things that outside your comfort zone. And that's why in every laboratory, I think, the many people, and there should be a collegial environment, a quite open environment, and even a shared operator environment, an accepting and shared operator environment. If of course, the patients have referred to a certain doctor, then they could also seek another operator with them. I mean, surgeons do that all the time, in my experience, and in the hospital, all the time. Someone is operating the valve and seeks a help for someone else to operate the aneurysm at the same time. They don't make a big fuss about who has what certificate. They just help each other. And that's what we may simply do. Forgetting the certifications and help each other.
That's a very nice summary.
Okay, David, could you summarize?
So I think we've had a really good day of lectures and conversation and chat, particularly this last session about CHIP, complex, high risk, what it is, what it means, the place for imaging, the place for atherectomy, rotablation, place for shockwave, etc. So thank you very much for joining us for this chat and summary wrap up of the afternoon session.
Thank you.